Good afternoon, everyone, and welcome to NMAC's fifth webinar for the HIV 50+ Strong and Healthy program. Before we get started, I would like to go over some housekeeping rules. When you logged onto the webinar, your microphones were automatically muted to reduce feedback noise. If you have any questions or comments throughout the webinar, please type them in the chat box below. We will have 10 to 15 minutes to address questions at the end of the presentation, and my colleague, Sable Nelson, will be helping and monitoring questions throughout the webinar. Additionally, this webinar is being recorded. A copy of the presentation will be emailed to everyone 24 hours after the webinar. You can also find a copy of the slides attached to the handout section of the GoToWebinar section. Now I want to welcome Dr. David Hardy from the Johns Hopkins University School of Medicine. Dr. Hardy, please take over.
Good afternoon and good morning for those of you who are joining this webinar today across the United States. I'm on the West Coast myself, so it is still good morning here, but I know there's a span there across the noon hour. First of all, I just wanted to congratulate you all for being part of the 50+ Strong and Healthy Club within MAC. I think it's a wonderful program that they've created for persons living with HIV who have made it to 50, which is a very important milestone in many people's lives. I think especially so in persons who are living with HIV. For the reasons that you will see.
You know, it's saying, and I just trying to say to you.
Hello? Can everyone hear me?
Hi, yes, we can hear you.
Great. I couldn't tell there. So what we're going to talk about today is an area of very active research in HIV treatment and how people are doing with HIV infection over time. I think the really important thing to look at here, as the title says, why are older adults with HIV at increased risk for multi-morbidity? And if persons aren't familiar perhaps with that word multi-morbidity, it just simply means that soon after antiretroviral therapy started working in around 1996, the medical community and the activist community all kind of patted ourselves on the back and thought, well, everyone's going to do well and things are going to go back completely to normal. And what we noticed over time was that probably wasn't entirely the case. And when we talk about multi-morbidity, what we're really focusing on is what's going on with individuals who are HIV positive on medication with fully suppressed virus in most situations, who are tolerating the medications well, living with suppressed viremia, and continuing to live a long and healthy life. And I think some of the indications that we'll go over in this slide presentation will sort of look at some of those signals that we have been seeing. We'll talk about how antiretroviral therapy may or may not contribute to that multi-morbidity conditions, and also talk about what can be done in terms of recognizing and responding medically to some of these issues. I'm going to try to leave plenty of time at the end of this presentation within the hour for questions, but hopefully we'll hit some of your bits of information that you may not have heard or knew about before. And thank you to Joanna Lopez for asking me to be involved in this program. So the current state of affairs, we know that because of antiretroviral therapy, persons with HIV are living for longer periods of time than ever before, which is a very important gift of the fact that antiretroviral therapy works. But we know that there have been detected some gaps between people living with and without HIV, both in terms of lifespan, in terms of long-term survival, and also what's called health span, looking at things such as physical and cognitive function and health-related quality of life, and also some, I'll add to that, comorbidities that we'll talk about today. So one of the things that's, I think, really important to recognize that prevention and management of these comorbidities is a priority, both for persons living with HIV and also with the clinicians who are helping to care for them, because it's not just about anti-HIV medication in terms of long and healthy lives with HIV anymore. From the CDC, we have some very important data, most up to the date, that came out at the end of last year, and actually looks at what's happening to the epidemic of HIV in the United States through 2017. In that year, there were just under 39,000 new persons reported with HIV infection. And what you can see there is that fully 17% of persons newly diagnosed with HIV were 50 years old or older. And although the highest peaks are still in individuals less than 30, we still know that persons over the age of 50 are being diagnosed with HIV as well. When you look at the men-women breakdown there, you see that includes about 15% of all men who were diagnosed with HIV in that year, but 25% of women. So this is something that seems to be impacting women more than men in terms of being diagnosed with HIV later in life. Looking at the CDC data again, kind of over the last 3 years in their surveillance information, we can see that the persons living with HIV over 50 years old are increasing over the past 3 to 4 years. You can see that kind of light teal colored bar there that was at 45% of all persons living with HIV in the United States were over 50, increased to 46%, and then in 2016, 48%. Whereas some of the other bars staying very stable, for example, the group between 20 and 34, still at 18%. Some, in fact, are going down for the individuals between 35 and 50, going down from 37 down to 33% this time. Which really points out the fact that although we haven't stopped new HIV transmissions, we have certainly seen persons who are HIV positive living longer over time. Now, what I want to do now is show you some slides from different kind of what's called cohort studies. As you probably may or may not know, cohort studies are clinical studies, but they're not clinical trials. No intervention is usually done. But these studies are done in order to be able to basically observe individuals with a certain health condition and see what the natural history of that health condition is all about. And I'll be presenting to you results from several different HIV health study cohorts, in which patients are followed over time to see how they are living and what kind of medical problems, if any, or other problems are occurring. Now, there's been a big Danish study going on for many years in which persons who are HIV positive, persons who are HIV negative are followed to look for different sorts of life outcomes. In this study done between 1996 and 2014, almost 20 years, they looked at the persons with HIV over 50 years old and were alive at least a year after their diagnosis. And there were about a little over 2,400 persons in that group. They matched that with individuals who are HIV non-infected by age and gender. What they found over this study, over about those 18 years, was that the deaths during this study were about 22% of HIV positive people and about 10% of persons who are HIV negative. What they noticed, however, also was that over this time, the median or sort of average survival time after the age of 50 increased by 10 years between 1999 and 2014. But it was still lower than the persons who are HIV negative. You can see in the bar there that adding those numbers at the top of each bar to the age of 50 tells you that people with HIV are living from 62 to 68 to 73 in terms of average lifespan. But that still is not quite what persons who are HIV negative are living to at age 80. So let's move on. In the United States, a similar sort of trend has been seen over the past many years, and some data from the Northern California Kaiser Research Group has been looking at this over the same kind of period of time. What they've noticed, for example, is that right at the beginning of the time when HIV medication started working, when the HART era of treatment began in 1996, there was about a 44-year gap between the life expectancy of an HIV positive individual, 19 plus 20 years, or 20 years plus 19 years at 39 average life expectancy, versus 83 for persons who were HIV negative. And what you can see is that over time, the HIV negative persons in the teal colored line at the top there has kind of bounced up and down, but stayed pretty much the same. So that by 2011, the life expectancy was still 65 plus 20, or 85 years old. I should stop and say that what this is really looking at is an individual who is 20 years old, and the numbers we're looking at are the number of years added after the age of 20. What has changed considerably, however, though, is looking at the green line in terms of the HIV positive individuals. And over this time, you can see that by 2008, that gap had narrowed from 44 years down to 13 years. So an HIV positive person was living to age, on average, age 67 versus 80 for an HIV negative person. And by 2011, the gap had narrowed a little bit more, 12 years, between 73 up to 85. But as you can see, with these data from the United States, Northern California, the difference is still pretty not exactly the same. There was a average life expectancy remaining after age 20 analysis that really looked at some of the factors that might be involved in these differences other than just HIV. As I said, there on the left side of the graph, the gap was about 13 years overall for the entire group. But when it was broken down for persons who had high T cells, meaning had high T cells, meaning over 500 cells at the time that their antiretroviral therapy was started, that gap overall decreased to 7.9 years. If the persons had no hepatitis B or no hepatitis C, no co-infection with the hepatitis virus, that gap further narrowed down to 7.2 years. If there was no substance use disorder, the gap further narrowed to 6.6. If there was no smoking, it decreased again to 5.4. And if there was none of these things, no co-infection with the hepatitis virus, no substance use disorder, or no smoking, it stayed about the same at 5.7 years. So there are other factors which we would call changeable factors, like substance use disorder, like smoking, and like hepatitis co-infection, which, at least in the case of hepatitis B, can now be cured, and with hepatitis B can be well controlled with medications, that are issues that could in fact be playing a role in keeping that gap at 13 years as opposed to allowing it to decrease. So there are some changeable sort of factors that can be dealt with in terms of extending the lifespan of a person with HIV infection. So I think one of the biggest questions that I've continued to hear over the past many years when individuals have heard these data, this information, was that there's a controversy. At first, people came up with the easy sort of answer that aging was accelerated or accentuated in persons living with HIV. But I hope to show you in the next couple of slides that that may not be entirely true, that accelerated aging or accentuated aging, or intense aging, I should say, is probably not happening in persons who are HIV positive. The age cohort from the Netherlands was looking at different sorts of age-associated non-communicable comorbidities. And what that basically means are things that are not caused by an infection, they're not transmitted from person to person, and they're comorbidities, meaning that they are medical problems that exist in addition to something else. And in this case, it's HIV infection for the HIV positives versus those who are negative. Over the different time periods there, from 45 to 49, 50 to 54, 55 to 60, up to over 65 years, number of these age-associated non-communicable diseases, which included things like cardiovascular disease, metabolic disease, meaning like diabetes, lung disease, kidney disease, bone disease, and cancer, were counted up among the positives and the negatives. And there were about 540 of these individuals in each of the arms of the H positive and negative groups. And what you can see is that at any one age, after the age of 50, the number of comorbidities is increased for the HIV positives versus the HIV negatives, which, as the red bars around the individuals who are over 65, there was a greater proportion, around 75% of HIV positive individuals had at least 2, if not 3, comorbid conditions versus 50% of those individuals over 65 who were HIV negative. So I think what this is really starting to tell us is that aging is not occurring faster or more intensely, but at any age point, some of these comorbidities are starting to pop up more quickly in greater numbers. However, on the other hand, there was also data that shows that that is in fact not happening. In a study called the Veterans Aging Cohort, which has been going on for about, well, since they started in 1996, but looking at these data from 2003 and 2010, researchers looked at whether or not myocardial infarctions, basically heart attacks, or non-AIDS cancers, meaning not Kaposi sarcoma and not lymphoma, or end-stage renal disease, kidney failure, was occurring at what ages in individuals who are HIV positive versus those who are HIV negative. They also added to this research.
Hi, Dr. Hardy. I'm sorry to interrupt. We're getting a few comments regarding some feedback, so I just want to make sure that you dialed in from your phone and turn off your computer speakers. Maybe it'll help with the feedback noise.
All right, let me dial into my phone real quick.
Okay, thank you.
Right. Can you see my slides again?
Yes, you're back up, but there is a slight echo.
Yeah, I hear that. My computer is turned off. My sound is turned off, but my phone is, for some reason, reverberating. I don't know why.
Yeah, as long as you have only one audio source, you shouldn't hear any echoes. So, yeah, so you should have only dialed in through your phone.
Yeah, let me see if I can let me go back and make sure that my speaker's completely muted. All right, sorry about that. Well, let's continue. So what I was explaining about the veterans aging cohort was that only for end-stage renal disease was there a difference in terms of when these three different comorbidities were occurring: heart attacks, non-AIDS cancers, and end-stage renal disease. That in this study, which included a large number of individuals, they did not see a significant difference at the ages at which these three different kind of serious medical problems were occurring, these comorbidities. And as you can see there, when they checked what's called the mean age, the adjusted differences in mean age, those differences were very small. And the notation that says P equal NS simply stands for the fact that there was a non-significant p-value, which means that the difference between the ages they were occurring in the positive persons versus the negative persons was not significantly different. So we have some data here that is telling us in one study that there are more comorbidities at each age in one group from Europe, but not in a similar group from the United States. So kind of what's underlying all of this, and there's been a lot of important research looking at the question of where this, perhaps this increased inflammation, increased number of adverse events or decreased lifespan is really coming from. And that really seems to hone in on one important concept, and that is persistent chronic inflammation, or what is also called immune activation. We know that during HIV infection, the immune system responds very vigorously against HIV. However, we also know that that response is not fully effective in being able to eradicate or suppress the virus on its own. When antiretroviral therapy is given, we know that that inflammation decreases dramatically, but we also know that it does not decrease to the level compared to an HIV uninfected patient, that there is still detectable evidence of chronic inflammation or immune activation that is persisting in persons who are well suppressed on anti-HIV medication. So where does this inflammation come from? There's probably several different sources, but the ones that have been most notably seen are continued HIV production and replication. Even though we cannot measure HIV less than 20 copies per ml with our most sensitive viral load test, we do know that there is oftentimes ability to measure lower quantities of HIV by even more ultra sensitive viral load tests that can measure down to as low as 1 copy. So we do know that there is some low-level production of HIV. You notice the slide doesn't always call it replication, because it may not be that the virus is actually going through new rounds of replication. It may be just that the virus is being produced, but not the normal replication pathway. That being true, our HIV medications cannot work against HIV production because the cells are simply dividing, releasing virus when they're activated, not the fact the virus is actually being actively replicated. There are also other kind of co-pathogens such as cytomegalovirus, herpes simplex virus, and human papillomavirus that seem to be more common in HIV positive versus HIV negative. All three of these viral infections are chronic, long-term viral infections, which our body can partially control but never completely eradicate. And that may also add to the chronic inflammation that is seen in persons who are HIV positive. We also know that there's some damage to the immune system that occurs with HIV infection, in which what's called immunoregulatory cells, or cells that basically are set up to turn off the inflammation, to down-regulate or slow down or shut down the immune system so that it stops reacting, are lost. And so those regulatory cells that are the turn-off switch for the immune activation don't seem to be working too well because of some sort of HIV effect problem. But the biggest thing that probably really contributes to this is what's called translocation of microbial products across damaged mucosal surfaces. We know that when someone first becomes infected with HIV, the site of the greatest number of T cells in the body, the gastrointestinal tract, or the layer of tissue just below the surface of the gastrointestinal tract in our small intestine and large intestine, those T cells get destroyed. And those T cells are there for a reason, to try to keep the things that we normally eat every day that contain bacteria, viruses, and funguses normally from coming across the gastrointestinal wall into the blood. When those cells are destroyed, that barrier all along the gastrointestinal tract starts to have holes in it. And a situation is created what's called leaky gut, so that small pieces of bacteria, small pieces of viruses that normally stay outside of our blood system, but inside our body and goes from our mouth through our anus during normal gastrointestinal functions, start to come into the bloodstream. And those small particles of bacteria and virus set up a situation where the immune system is reacting against them now that they're in the body, in the blood. And again, this could be a source of chronic inflammation and immune activation as well. How to best control this kind of chronic inflammation is a very active area of research, and many studies are going on around the world, particularly within the AIDS clinical trials group, the ACTG, to see if there are ways that we can decrease this inflammation in persons who are HIV positive and will suppress on their medications. So we're going to move a little bit over to about starting antiretroviral therapy. We know that all the guidelines in the U.S., the EHHS and the IAS USA guidelines, as well as those outside the U.S., recommend antiretroviral therapy for all persons with HIV, regardless of T cell count, to not only reduce the increase in survival and decrease the complications of HIV, but also to stop transmission from one person to the other. We also know from large clinical studies, like the SMART study, which actually compared two different strategies for treating HIV infection. And this was back in the days when many of our medications were very hard for people to take continuously, of having treatment interruptions. The SMART study had one half of the people who stayed on their medication consistently, and the other half of the study went on and went off based upon how high their T cell count was. The START study that was done later was a study that gave immediate antiretroviral therapy to persons with T cells over 500, meaning a normal T cell count, versus a delayed delayed initiation of antiretroviral medication only when T cells are about below 350. One of the things that came out of both of these studies was the fact that not only were AIDS events that we knew were associated with HIV infection lower when medication was used continuously and also early, but also serious non-AIDS events such as cardiovascular disease, cancer, and other non-AIDS events were occurring less commonly in persons who were on continuous treatment and earlier treatment. And the graph there to the right really shows what's called a hazard ratio, the chances of someone developing one of these problems if they did not receive immediate or continuous antiretroviral therapy. And you can see all the green dots are in a section greater than 1, which means that the risk to those persons who had discontinuous therapy or later therapy were higher for not only AIDS, but also other kinds of complications that didn't commonly associate with being HIV related. The START study also went on to look at different age groups. And you can see that these three groups of persons, less than 30, between 30 up to 49, and then greater than 50, that the differences between immediate medication, immediate antiretroviral therapy versus deferred antiretroviral therapy increased as persons in the study were older at the initiation of the study. So that in those individuals who are greater than 50, there was a large difference between when the effects of what happened when people started medication in terms of developing not only HIV-related events like opportunistic infections and opportunistic cancers, but also non-AIDS events like cardiovascular disease, including heart attacks and strokes, liver disease, bone disease, and kidney disease. These are, I think, very important findings that tell us that antiretroviral therapy does more when it's used early and continuously than what we thought it might do early on. So the current DHHS and IAS USA recommendations are shown on this slide, and basically what it's telling us is that all first-line preferred medications for most people as initial therapy are all integrase inhibitor-based treatments paired with either two nucleosides like abacavir 3-TC or FTC and TAF, or FTC and tenofovir. The two different recommending organizations have some differences there, as you can see, with raltegravir being in the DHS recommendations and not in the IAS-USA, and only TAF being in the IAS-USA, but still in the DHHS recommendation. So we've really, I think, come up with some much easier and straightforward sort of way of being to recommend HIV therapy than ever before. What the DHHS says about aging and initial therapy is that there's no evidence that virologic response to antiretroviral therapy differs in older versus younger patients, still the same. What is found is that observational studies have shown a higher rate of viral load suppression for persons over 50, those who are younger, probably because of improved adherence. It's also known that in individuals who are older, their T cells recover or start to go back up after treatment more slowly and in a lower magnitude than persons who are younger. And this observation really points out the fact that starting antiretroviral therapy at a younger age, as soon as diagnosis occurs, is very important for a better immune response and possibly better clinical outcomes. So let's look at a patient that's pretty typical, I think, for most persons living with HIV around the U.S. today. This is a 45-year-old treatment-naive male with a history of cardiovascular disease. He was recently diagnosed, or at least was ready to deal with his HIV infection, and became ready and willing to start transmission. His HIV RNA is about 157,000 copies, considered to be a high level. CD4 cell counts are decreased, but not terrible, at 350. And as you can see there, he has hypertension. His body weight is over 30 kilograms per meter squared, so he's considered to be obese. But his fasting glucose is not too bad at 115. Doesn't look like he has diabetes based upon that. His cholesterol levels show that his HDL cholesterol is good cholesterol. Protective cholesterol is low, so it's less than 40. And his bad cholesterol, or LDL cholesterol, is a bit high, but not terrible. He does smoke tobacco, which is, of course, a risk factor. He uses moderate alcohol, but no drugs. He's employed in a stable job and also a stable relationship with a person who's HIV negative. So one of the things that popped up at the recent COI conference in Seattle this year was the fact that the San Francisco Health Department looked at the association between what's called sudden cardiac death and HIV. What they found when they compared HIV-infected sudden cardiac deaths compared to HIV negatives is that all sudden deaths were 86% higher in HIV positives. Sudden arrhythmic deaths, meaning that an irregular heart rate actually led to death, were 58% higher. And an autopsy, meaning they looked at the patient's hearts, there was more myocardial fibrosis, which means that the heart muscle itself was having a lot of scar tissue in it, which decreases its function and ability to work well, and that was about 72% higher. It was known that people with HIV with normal CD4 cell counts and low HIV viral loads were still at risk for this sudden cardiac death. And it was also noted that, curiously, that some of these cases of sudden cardiac death were due to occult overdoses of medications in 34% of HIV positives, compared to 13% of individuals who are HIV negative. And this was, I think, sort of a wake-up call to say that when people die of a heart attack, we oftentimes just attribute it to heart disease, but that's something that seems, in the San Francisco study, occurring more commonly in HIV positive persons than HIV negative persons. And again, it gives us that indication that we need to look for these sort of medical problems earlier and in a more detailed fashion than we do in HIV negative persons. One question that's been lingering around for a long period of time was to really look at what is the contribution of controlled, well-suppressed HIV disease as a cardiovascular risk factor. And I'm just going to cut to the chase and ask you to look at the graph on the right-hand side, because this actually is the the accumulation of some very, very good research in a very large number of patients, in which in the Shaw meta-analysis, they tried to put a number on what the risk factor of HIV was compared to other well-known cardiac risk factors. The Interheart study is a very, very large study that looked at all different kinds of risk factors for having a heart attack. That include high blood pressure, hypertension, diabetes, high lipids, and smoking. You can see there in the lower half of the graph that high lipids have a 4-time increased risk of a heart attack versus those who had low lipids. Smoking has over a 3-fold increase in chances of a heart attack. Diabetes 3 times, and hypertension about 2.5. When we look at where HIV actually lies in comparison to those, it's over 2-fold increase just by HIV alone. And I think this is something that we really need to step up and take notice of, because HIV is generally not included in one of the risk factors for cardiovascular disease. This next slide really makes a good point of that. Commonly in the United States, we used to use what's called the Framingham risk score to calculate what a person's chances of having a heart attack in the next 10 years would be. That risk score has been updated to now be used what's called the ASCVD score that the American College of Cardiology and the American Heart Association have created over on the right side of the slide. And as you can see, when there has been data comparing observed heart attacks or cardiovascular disease in HIV positives versus predicted by either one of these risk scores, the observed has been higher in both cases with either one of these risk calculators. And what many people suspect is that what is missing in those risk calculators is the effect that HIV infection itself brings to the table and causes some effect, in addition to the already long time recognized risk factors such as high blood pressure, diabetes, smoking, and in fact being male. So one thing we can do certainly about this is as an example of one of the controllable effects of cardiovascular disease is certainly high cholesterol. And there are very simple behavioral modification sorts of things that can be used in terms of diet, exercise, and certainly smoking cessation, but also pharmacologic medications as well, including statins and other medications that can be used as well. And those are something we're not going to go into detail here, but just to know that there are ways that high lipids, which has over a 3-fold increase in having a heart attack for everyone, including HIV positive persons, can in fact be dealt with. The lower part of this slide really looks at what we have learned about our HIV medications. We know from the past that anything that is boosted, whether it's a protease inhibitor or an integrase inhibitor, whether it's ritonavir or cobicistat, or also our older drug efavirenz, Sestiva, have caused increased lipids. And it's been recommended we step away from those medications in persons who are HIV positives. We know that our newer medications like dolutegravir or Tivicay, Triumeq, raltegravir, Icentris, and rilpivirine, and also included in that list bictegravir now, or Biktarvy, have lower effects or very few effects on raising lipids. Interestingly, the medication tenofovir also has a lipid lowering effect when it's compared to abacavir or to TAF, which is something that becomes a little bit of a yin-yang whether or not we use tenofovir, because it also has, as you know, kidney and bone mineral downsides. When we actually look at the initial risk look at the initial treatment of HIV, when someone has high cardiac risk, like our 45-year-old patient here, we know that we want to really concentrate on those medications that do not cause increased cardiovascular risk factors. So the recommendation to use a integrase-based regimen like a bictegravir, dolutegravir, raltegravir, or newer NNRTI regimen with doravirine or rilpivirine are really recommended. It's also recommended that medications which have clearly or possibly been associated with an increased risk of cardiovascular disease, such as abacavir, Xiagen, or lopinavir ritonavir, called Kaletra, not be used. Again, we know that boosters actually increase lipids, so we try to stay away from anything that's boosted. But if a booster has to be given with a protease inhibitor because of the patient's viral resistance, then atazanavir or Rayataz boosted medication regimens have been shown to have fewer heart attacks associated with it than darunavir or Prezista medications. We also know in terms of kidney disease, which is the next thing that oftentimes occurs, because many times we know that the risk factors that are associated with having heart disease also are associated with having kidney disease. So in terms of ways that we can look at initial treatment to avoid kidney disease, probably the most important thing is to stay away from anything that contains tenofovir, or in the case of tenofovir difumarate or DF. The newer use of tenofovir alafenamide or TAF, or the use of abacavir for kidney disease, seems to be much less of a risk for causing problems compared to tenofovir DF, the older tenofovir. Avoiding atazanavir or Rayataz is recommended because they can cause kidney stones and renal failure because of that. And we also know that when abacavir or tenofovir AF are combined with protease inhibitors, with integrase inhibitors, good results usually occur. The other things that can be used in persons who have kidney disease are nucleoside or regimens that do not contain nucleosides or NRTIs, such as or contain what's called a friendly NRTI like lamivudine. So the use of dolutegravir lamivudine, which is recently licensed in the United States as an option for treatment for initial therapy. Darunavir and lamivudine could be used, and also darunavir plus raltegravir, using no nucleosides at all. So there are ways that one can avoid both kidney and heart disease by carefully choosing antiretroviral therapy. I'm going to move on now to a second patient named Jean, who's a 69-year-old woman, and she's coming in to see her physician or her care provider about 3 weeks after she got out of the hospital, when she was hospitalized for pneumonia. She's complaining of feeling weak. She has little appetite. She's lost about 6 pounds. She was previously 102 pounds. She's now down to 96 pounds. She sometimes requires a cane for walking. She has osteopenia, some bone thinning on her DEXA scan. And while she was in the hospital for pneumonia, they did a CT scan, did not find any cancer problems, which smokers can have, and she is a former smoker. And her discharge medications included a new inhaler, an antibiotic for pneumonia, and supplemental oxygen. She's been living with HIV for a long time, 23 years, due to her former injection drug use. And she currently remains on efavirenz, emtricitabine, or tenofovir, also known as a tripla. Her viral load is well suppressed, less than 50, and her CD4 cell count is in the normal range at 550. She has some episodes of malnutrition as one of her comorbidities. She used to smoke for a long time. She uses minimal alcohol, and she's a former injection drug user, but has been sober for 22 years. Retired and widowed. One of the things that starts to come up here that is perhaps also being seen more commonly and is associated with negative health outcomes is the concept of what's called frailty. And frailty is a sort of a finding of body type and function, which is oftentimes associated with aging. We can see in this chart from a research done by Stoff and others that there's a classification of persons starting at the bottom and moving up with what's called successful aging, well-being and satisfaction with life, resilience, positive traits, premature or accelerated aging, in which some of the aging process seems to be occurring faster, cognitive aging, or having trouble with situations like memory, attention span, executive function and motor function of the brain and language, comorbid aging, in which there's 2 or more medically diagnosed diseases, and then frailty, which is really defined as a physiologic state of increased vulnerability to stressors, meaning that the person seems to be in a situation where they are more easily affected by stress things in their life. And then finally, disability, which means that they're now dependent, or it's very difficult to carry out activities of independent living. The concept of frailty is something that has been discussed in geriatrics for a long period of time. And to tell you the truth, because many of our persons who are living with HIV infection today are in the geriatric population, frailty has really become a commonly discussed and looked for part of aging with HIV. We know that things such as what's called shrinking or unintentional weight loss of greater than 10 pounds, sarcopenia means muscle loss, muscle weakness, poor endurance or exhaustion, slowness, meaning walking slower than usual, and low activity, meaning not burning many calories every day, are all parts of the concept of frailty. It's been known from the aging cohort from the Netherlands, the age HIV cohort, that frailty in persons with HIV versus those without HIV, again, seems to be occurring in a higher proportion of patients at each individual age group. As you can see going across there is more commonly in the green bars a diagnosis of frailty, as we talked about in the previous slide, in persons who are HIV positive versus those who are HIV negative at every age comparison. Looking at the individual sort of concepts of or pieces of frailty, such as weight loss, weakness, exhaustion, slowness, or low physical activity. Again, these symptoms seem to be more commonly found in persons with HIV than those persons without HIV. So what does frailty actually equate to? The study also went on to show what the effect of frailty was all about in terms of how it affected person's lifespan. And what they found in this study, as you can see in the graph to the right, that the persons who were frail versus those who were pre-frail versus those who had a robust body activity and function were significantly different. And this seemed to be occurring more commonly, 96% of persons who are HIV positive compared to lower numbers of individuals who are HIV negative. And this is something, again, that one needs to look at more carefully in terms of trying to prevent things that are associated with this, particularly survival. The Women's Interagency HIV Study, oftentimes called the Y study or the Women's Study, is a study that's been going on since 1994 and has been running parallel groups of HIV positive women compared to HIV negative women. And the interesting thing about this was that this study, done in women particularly, did not find frailty being associated with falls. And why are we talking about falls? And that is because as people age, the chances of falling and hurting oneself, breaking a hip, breaking a different bone, hurting themselves in other ways, such as a head trauma, head injuries, seem to occur more commonly. So falls are oftentimes the outcome of a person becoming frail. When they compared the HIV negatives versus HIV positives, as you see there, single and recurrent falls did not occur more commonly in HIV positive women versus HIV negative women, which was something that I thought was very important, except for there was a small increase in terms of the multiple fall women who were considered to be frail as a significant predictor, but not for single falls at all. So there's some data here that, again, is showing that frailty may not be as important, at least in women, from this study. So getting back to Jean, her main complaint during the current visit is that she's been having trouble sleeping and feels dizzy. And what could be the cause of that? Well, she's on many medications, and efavirenz containing a triplet, which can interrupt sleep very commonly. Levofloxacin, prednisone, vitamin D, calcium, enalapril, omeprazole, all medications for her infection, for her bone disease, osteopenia, calcium for osteopenia, enalapril for her hypertension and omeprazole because of her high acid in her stomach. She's also on inhalers that contain steroids, also for her COPD. We see there that one thing we got to be careful about is the fact that women who are, and men who are frail, oftentimes have a higher rate of fractures, of having those falls or injuries that actually cause bones to break. And the HOPS cohort, which is a long time running cohort of HIV positive persons in many different practices and clinics around the United States, when we looked at data over the 18-year period between 2000 and 2017, they found that there was an association with new fractures and mortality, meaning that when persons had a fracture, they had a higher chances of actually dying because the fracture was sort of a predictor that things were not going well for that person. As you can see over the time period there, the mortality with persons with fractures has been decreasing from 2000 to 2017. The age has been increasing the opposite direction, and the CD4 cell count has been going up, all of which is great news that there is less death. People are in fact living longer and surviving, and their T cells at each point seem to be increasingly higher. At the bottom there, what was associated with death in those persons who did die was chronic kidney disease, hepatitis C co-infection, and non-AIDS cancers. Again, something that we've heard many times before from previous studies, that these are the things that seem to be now the new causes of death in persons who are HIV positive. The same kind of information actually came from the VA cohort, primarily a male cohort following people with HIV over a long period of time, and they looked at their insurance claims data and tried to see whether or not persons who were HIV positive did in fact have more fractures than those who had HIV negative. And when the first fracture occurred, fractures of the hip, wrist, or of the back, the spine, the vertebra. As you can see there, the total fractures were in fact higher in HIV positives than HIV negatives, and were higher significantly at the hip, but not at the back or the wrist. When they looked at the risk factors for having those fractures, there was a small increase of being HIV positive, about a 38% increase in having a fracture in an HIV positive person versus HIV negative person. A prior fracture really increased that by 8 times. Being underweight, meaning being frail, was also almost a 3-fold increase, and using drugs or alcohol was about a 48% or 50, almost a 50% increase in chance of having a fracture as well. And these are well-known reasons fractures can occur. But there also, this really points out there are some changeable things that can be done. Getting back to Dean, one of the things that has also become a problem for many people as they age, not just HIV positive persons, but because we know HIV positive persons are usually going to be on at least 3 medications, meaning they're HIV medications, and then multiple medications for other kind of comorbid conditions. As you see here from this one study, one site of 359 patients, persons who were on stable antiretroviral therapy and doing well with undetectable viral load were between 45 and 65 years old, that the chances of having a fall with different medication classes were shown in the table on the right. If a patient was taking an antidepressant, there was a 3.5-fold increase of having a fall. A beta blocker, a medication commonly used for high blood pressure, a 3.4 increase in chances. Opiates, because of changes in cognitive mental function, 3.4. And as you go down there, you see that there are several medications that increase the chances of falls. And of course, using several of these medication classes at the same time can also only multiply those risks as well. Now, the VA aging cohort has also looked at non-HIV medication, multiple medications, adverse outcomes. When they looked at HIV positives, almost 10,000 of those individuals versus HIV negatives, about 40,000, who were 80% were over 50 years of age. and had a similar distribution of common comorbidities and use of non-ART medications, what they found here is that there was in fact a greater use of medications in the HIV negatives than HIV positives, which was kind of an interesting situation that really didn't actually correlate with what we thought before. There was a difference, however, in the percent increase in mortality risk with more medications. For HIV positives, it was 20% for 2 medications or more, 49% for HIV negatives, and 43% for both of the groups who were on at least 5 medications. So this is something, again, tells us that the multiple medications may not be causing the biggest problems in terms of adverse health outcomes in general. So again, there's still some conflicting data here. So getting back to Jean, what can we do to help can we decline her decline in frailty, her function, and her everyday factors be done? Should we do anything more about her osteopenia, her early bone weakening? And what about her HIV medications, her efavirenz, her emtricitabine, tenofovir, or her Atripla? We know the biggest thing that causes problems with bones, again, is tenofovir. As we talked about before, tenofovir has been well associated with thinning in both men and women. And one of the strongest recommendations now is that if a person is aging and is going to have normal bone thinning or osteopenia, osteoporosis, that it's very important to avoid tenofovir DF in all those patients. The use of abacavir or the new form of tenofovir called TAF should be done. And that's something that, again, should be very carefully used. We may also think about creating regimens that contain no nucleosides whatsoever, no abacavir, no tenofovir at all, to really decrease the chances of osteoporosis. When TAF and the older form of tenofovir DF have been compared, looking at the rigidity, the strength of the bone mineral density in the spine and at the hips, you see patients who are switched over to TAF in the green line there versus those who remain on tenofovir have different sort of bone trajectories. The patients who got switched to TAF at the beginning of the study had about after 2 years, had about a 2% increase in their bone mineral density versus small decreases and probably continued small decreases in those persons who were on tenofovir. So switching from tenofovir DF to tenofovir TAF does in fact have a good effect on the bones, that the minerals that are in the bones are no longer leached out, the calcium and the phosphorus, which makes the bone strong. The same kind of situation was noticed in the SWORD study, when patients, 70% of which were on a tenofovir-based regimen, were switched off of that regimen versus staying on that regimen. The patients who got switched got dolutegravir or Tivicay plus rilpivirine, Edurant, and is now the combination in the pill called Juluca. You can see that in the green versus the teal color. Those who switched actually had about a 1.3% increase at 1 year in their bone mineral density versus those who stayed on their old medication, 70% of which contained tenofovir. So one thing that we have also come up with is that as people age, the number of age-related screening tests to look for things such as colon cancer, breast cancer, prostate cancer, cardiovascular disease, kidney disease, are really tied to the aging process. What we've noticed as an example for bone disorders is that for many years it was recommended that all women over the age of 65 and all men over the age of 70 have a DEXA scan to see whether or not their bones are thinning and need treatment for that. When this was actually evaluated for HIV positive individuals, it was found that that DEXA scan should not be delayed until the age 65 or 70. But yet differently, that DEXA scan, that screening test looking for bone weakness, should be done in all HIV positive women after menopause or over the age of 50, whichever comes first, and all HIV positive men over 50 as well, because it's been demonstrated that persons with HIV have a higher rate of osteoporosis or bone thinning than those persons who are HIV negative. I think that's something that, again, tells us that earlier screening will hopefully detect some of these things that may actually cause these problems. Other sorts of things that we know are associated with bone disease and oftentimes are more common in HIV positive persons and HIV negatives, such as smoking, such as weight-bearing exercise, and vitamin D, calcium intake, lack of that, are something that needs to be also addressed at the same time when thinking about bone disease. I'm going to sum up and just get a couple of takeaway messages and say that, number one, there have been several reliable studies that have shown that a higher proportion of persons living with HIV have non-HIV related health conditions such as cardiovascular disease, kidney disease, and bone thinning disease and frailty compared to HIV negative persons at the same age. This is not likely premature or accelerated aging, but just increased chances of having some of these non-HIV medical conditions at the same age. The cause of these problems are probably the continuation of chronic low-level inflammation or immune activation due to suppressed but still present HIV, due to co-pathogens such as cytomegalovirus, herpes simplex virus, or the human papillomavirus, some types of antiretroviral therapy, and the concept of a leaky gut. The bacteria and other pieces of microorganisms cross through the weakened intestinal barrier. And this is really probably the cause of this increased number of non-HIV diseases at the same age. We know that starting antiretroviral therapy as early as possible after an HIV diagnosis and avoiding many of our older antiretrovirals prevents or decreases the chance of these non-HIV diseases occurring. And finally, recommendations that are HIV specific for screening individuals, oftentimes at an earlier age, but certainly at the age recommended and not waiting until later, really needs to be done because there may be early signs that there is a greater risk of having non-HIV related cancers such as colon cancer, prostate cancer, lung cancer, cardiovascular disease. And these things should be carefully discussed with a patient's care provider to make sure that these screenings are occurring either at an earlier age or at certainly the recommended age. I'm going to stop there, and I know I've given you lots of information, and I'm sorry I went over time a little bit, but I'm certainly willing to stay on the line for questions if you have any. Thank you very much for your attention.
Yeah, thank you, Dr. Hardy. We do have a few questions in the chat box window, and we want to thank you, everyone. I know we're going over 3 p.m., but if you want to stay on 5 or 10 more minutes so we can address questions, that'd be great. The first question we have is from Michelle Lopez, and she's asking, should we be looking at new quality indicators as it relates to the growing needs of clinical care coordination for the aging population? What recommendations can you give in reference to care coordination for the aging individual living with HIV, navigating multiple specialty providers?
That's a great question, Michelle. You know, this is something in which, like a lot of different kinds of new advances in HIV medicine, we are learning about these, and we're learning that there are already many good sources of help out there. You know, one of the things that I've really become much more aware of is that as people are aging, it's sometimes sort of a new concept that the shift moves away from suppressing the virus, because that oftentimes becomes a given with our new medications and the ease of taking them and their effectiveness, to really looking at other important health conditions. So one thing I've certainly done in my practice, and also in persons that I give advice to, is that the care of an HIV positive person should always have antiretroviral therapy and adherence to it included in medical visits. But the real majority of time should probably be spent on the screening of that person for different age-related health conditions, making very sure that the colonoscopy is done at age 50 or earlier if there's any indication that colon cancer might be in the person's family or reason in other situations. That lung cancer be carefully checked for with a CT scan in any person who has smoked more than 30 pack years. For women, certainly doing cervical screening is very important for HIV positive women, and following up on those screenings if there is any indication they're abnormal. We may say the same thing at some point about anal pap screening for men who have HPV found in the anus. Those recommendations still remain a bit fuzzy because the study that is really trying to determine that screening and how to handle HPV or early dysplasia in the anus, how that's best handled is not entirely clear. But certainly all men who've ever been exposed to HPV anally, and that's probably all of us, should have an anal pap, and that should be repeated on at least an annual, if not more, basis, depending upon activity. So I think, the important thing I've learned is to shift one's medical care, not as only focused on HIV and antiretroviral therapy, but really looking at the whole patient, and particularly at those issues of aging. Coordinating this is a bigger situation than oftentimes we used to do with many people who we just give anti-HIV medication to, and hopefully we're surviving. Those days are over. We know that the majority of HIV people are going to be suppressed, are going to take their medications for a long time, and we really need to be aware of how we can limit those medication-related side effects, both the HIV therapies and non-HIV therapies, but also being more alert, being more vigilant of looking for signs of comorbidities at an earlier age. Does that answer your question?
Thanks, Dr. Hardy. I hope it answers your questions. Please follow up, Michelle, if it doesn't. So the next questions we have refer to slide 10 in your presentation. So the question from Robert is, please explain the number differential on slide 10 about comorbidities. The number of HIV positive participants is roughly half the number of HIV negative participants.
Yeah, okay.
And Wanda also wants to know do we have any data showing the distinction difference between men and women on slide 10 as well?
Yeah. I can answer the second question first kind of easily. And simply just to say that, I'm looking this really make sure that I'm looking at all this right. So I'm sharing my screen with you to kind of get a little more information about this slide. The majority of individuals followed in this study are in fact male, because this is coming from the veterans cohort study, meaning that most of the patients in veteran hospitals are in fact male. I would say probably around 90 to 95% of the individuals in this cohort are in fact male patients. So we don't have nearly as much information about this from this particular study. Where we do gain a lot of information about women and aging and long-term treated HIV is from the WISE study, the Women's Interagency AIDS study, and that's the one that really I would refer you to for information about HIV and aging for women. In this study, they actually evaluated almost 100,000 patients who were matched by age and by other factors such as race, smoking, alcohol use, and depression. And what they found when they did this matching of HIV positives, HIV negatives, is that there was a higher proportion of persons with HIV who had hepatitis co-infection with B or C virus, had cocaine-related diagnosis, had a normal versus an increased BMI, meaning less obesity in the HIV positives, but also who had a higher rate of having decreased kidney function, more kidney disease, but a lower chance of having diabetes, high blood pressure, high lipids, or as I mentioned, less obesity. So this was actually a pretty big group of about 100,000 patients followed for about 8 years between 2003 and 2010. And what they did in this actually even larger study, they just looked at 3 age-related problems here and looked at when these problems were occurring in the HIV positives versus the HIV negatives. And what you can see here is that the overall number. I see what you're talking about. You know what this study did. Why is there double as much negatives as positives? Let me get to your answer for that one. It's because this was what's called a 2-to-1 match. In this study, they picked the HIV positive individuals first, so they identified them first in the VA system, and then they found two HIV negative patients, which matched that individual patient based upon age, race, smoking status, alcohol-related diagnosis, and depression. So this study was set up as a cohort. Somewhat similar, they were matched. Those 5 factors I just mentioned, and they did that purposely so they would have a greater chance of being able to really compare the HIV positive versus HIV negative. So that's why there's twice as many numbers, or about twice as many for the negative patients versus the positive patients. I hope that answered the question.
Great. Thank you, Dr. Hardy. We have a few more questions, but I think it's time to wrap up now. We want to be respectful of everyone's time and your time. So thank you, everyone, for joining. We will address those questions that we didn't get to. I will email them to Dr. Hardy, and he can follow up with you any other additional questions you may have.
That'd be great.
Once again, thank you for joining, and we apologize for the static that you may have heard throughout the webinar. Hopefully the recording will be much clearer.
Thank you very much.
Again, thanks, everyone. Thank you, Dr. Hardy. Have a good weekend.
Sure. Bye.
Bye.
What is that happening?